Now, hi, we're Module 6, Group 5. I'm Trina Reed.
I'm Alyssa.
And I'm Steven.
Okay, this presentation will review concepts from the NADAC Module 2 on addressing relapse and apply those principles to a fictional case study involving severe methamphetamine use disorder. We'll walk through relapse as a process, assessment tools, ASAM criteria, and treatment planning using best practice approaches. Today's presentation explores relapse as a process rather than a failure. A key concept in the NADAC Module 2, relapse often develops through emotional, cognitive, and behavioral shifts that can occur before substance use resumes. Understanding relapse this way will allow counselors to intervene earlier, reduce shame, and support continued treatment engagement rather than viewing relapse as a reason for punishment or discharge. These concepts will be applied to a fictional case study involving severe methamphetamine use disorder using evidence-based screeners and the ASAM criteria. We will examine relapse risk, readiness for change, and level of care recommendations. This approach demonstrates how structured assessment supports ethical, client-centered treatment planning and long-term recovery. NADAC Module 2 emphasizes understanding relapse as a process rather than a single moment of failure. This process often begins with emotional and cognitive changes that occur before substance use resumes, such as increased stress, emotional withdrawal, negative thinking, or decreased use of coping skills. Viewing relapse through the lens allows counselors to move away from blame-based responses and instead focus on identifying early warning signs that signaled increased vulnerability. Relapse risk is further influenced by neurobiological changes, environmental stressors, and learned behavior patterns associated with substance use. Chronic substance use alters the brain's reward and stress system, increasing sensitivity to triggers and reducing impulse control during periods of stress. For this reason, NADAC highlights the importance of early intervention, ongoing assessments, and treatment adjustments to reduce relapse risk and support sustained recovery rather than waiting until substance use has already occurred. NADAC highlights that relapse vulnerability is often shaped by a combination of stress, environmental exposure, and gaps in coping resources. Increased stress levels, emotional dysregulation, and ongoing exposure to triggering situations can gradually erode a client's ability to manage cravings effectively. When coping skills or recovery supports are limited, clients may begin to disengage from treatment or rely on old patterns to manage stress. Trauma exposure and untreated mental health symptoms further compound relapse risk by intensifying emotional responses and reduce problem-solving capacity. Anxiety and depressive symptoms may increase avoidance behaviors or weaken motivation for recovery. NADAC emphasizes that early identification of these factors allows counselors to strengthen supports, modify treatment plans, and intervene before relapse escalates into substance use. NADAC emphasizes that counselor responses to relapse should be non-punitive and non-shaming, as punitive reactions can undermine engagement and increase risk for continued substance use. Relapse is viewed as meaningful clinical information rather than a personal failure, signaling the need for reassessment rather than discharge or punishment. Responding in this way helps preserve the therapeutic alliance and supports client dignity and motivation. Best practice responses focus on collaboration, reassessment, and treatment adjustment. Counselors are encouraged to explore contributing factors, reassess ASAM dimensions, and determine whether changes in interventions or level of care are warranted. Ethically, counselors must balance accountability with compassion by supporting continued care and promoting client autonomy and prioritizing safety throughout the recovery process. Relapse prevention is ongoing, individualized process that requires treatment planning to remain flexible and responsive to client needs. NADAC emphasizes matching interventions to a client's readiness for change, current risk factors, and available supports rather than relying on statistic or standardized plans. As recovery progresses, clients' needs may shift, making reassessment a critical component of effective care. Using structured tools such as the ASAM criteria and standardized screeners allows counselors to monitor changes in risk functioning, and motivation over time. This ongoing assessment supports timely adjustments to treatment intensity, interventions, and level of care. Approaching relapse prevention as a continuous process prepares counselors to respond proactively to emerging risks and better support sustained recovery.
Now, here is our case study. Jason Anderson, a 30-year-old white male who works in construction and presents with severe methamphetamine use disorder. His substance use initially began with smoking methamphetamine and escalated over time to intravenous use. Jason was referred for treatment following a serious incident in which he was arrested for a DWI while driving under the influence of methamphetamine with his children in the vehicle. As a result of this incident, Jason spent several days in jail, lost his employment, and his wife relocated with their children to live with her mother. Jason's presenting problem includes loss of control over methamphetamine use, escalating tolerance, and continued use despite significant legal, occupational, and family consequences. He reports difficulty maintaining sobriety, impaired judgment while using, and increased stress related to the separation from his family and unemployment. These factors place Jason at a high risk for continued use and relapse, highlighting the need for comprehensive assessment and a higher level of care. Next, we will review key biopsychosocial factors that contribute to Jason's substance use and relapse risk. This slide provides a high-level biopsychosocial snapshot of Jason's presentation. Jason is a 30-year-old construction worker whose methamphetamine use escalated from smoking to intravenous use, leading to significant functional impairment. The client reported his use escalated over the past month, using around a gram daily during his binges. The most acute catalyst for treatment was a DWI while under the influence with his children present, which resulted in legal involvement, short-term incarceration, job loss, and marital separation. These cumulative consequences highlight the severity of his substance use and its impact across multiple life domains. Client reporting being to use alcohol and cannabis at age beginning to use alcohol and cannabis at age 16 in high school. Client's use escalated over time to methamphetamines due to his construction work and a desire to be more proactive. Following his DWI, job loss, and family separation, the client reported his use escalating over the past month, using around a gram daily during his binges. From a biopsychosocial perspective, Jason's substance use is reinforced by limited sober supports, unresolved family of origin trauma involving exposure to domestic violence, and poor physical health maintenance. Medically unmanaged hypertension, dental neglect, sleep disruption, and IV drug use increase the risk of his complications. Socially, separation from his spouse and children has intensified stress, guilt, and isolation. Together, these factors contribute to relapse vulnerability and underscore the need for structured, comprehensive treatment addressing biological stabilization, psychosocial supports, and behavioral change. Multiple psychometric screeners were administered to better understand the client's trauma exposure, stress level, substance use severity, emotional functioning, and readiness for change. The client's ACE score of 6 indicates significant childhood adversity, including emotional and physical neglect, exposure to domestic violence, parental separation, and household substance use. Scores of 4 or higher are associated with increased risk for substance use disorders and emotional dysregulation. supporting a trauma-informed treatment approach. The Holmes Race score of 457 places the client well above the 300-point threshold, indicating an estimated 80% risk of stress-related health problems. This reflects recent cumulative stressors, including incarceration, job loss, marital separation, housing instability, financial strain, and disrupted sleep and eating patterns, all of which increase relapse vulnerability. The ASSIST results indicate high-risk dependent level methamphetamine use with a score of 39, supported by daily use, strong cravings, significant functional impairment, legal consequences, and recent IV use. Elevated cannabis and tobacco scores suggest polysubstance involvement, though methamphetamine remains the primary substance of concern. The RCQ-TV places the client in the contemplation stage of change, meaning he acknowledges the seriousness of his substance use but remains ambivalent about full behavioral commitment. This highlights the importance of motivational enhancement rather than confrontational approaches. Finally, the OQ45 score of 121 indicates severe psychological distress across emotional, interpersonal, and role functioning domains, consistent with the client's legal stress, family separation, and substance use severity. Together, these screening results support a diagnosis of severe stimulant use disorder and guide both the level of care and treatment planning decisions discussed in subsequent slides.
So based on the clinical interview, the biopsychosocial, and the screening results, the client meets DSM-5 criteria for stimulant use disorder severe with methamphetamine as the primary substance. The severity is supported by the loss of control while using, increased tolerance, continued use despite legal consequences, occupational consequences, and family consequences. The client shows impaired functioning and engagement in high-risk behaviors, including IV use and driving under the influence with children. Several Z codes we identified to capture key psychosocial stressors impacting treatment were Z56.0, reflects recent unemployment, Z63.5, captures marital separation and disruption of family relationships, and Z65.8 represents ongoing legal and financial stressors. Moving on to the ASAM, ASAM dimension 1 indicates a high risk due to daily IV methamphetamine use. This places the client at significant risk for withdrawal complications and medical instability. Dimension 2 reflects unmanaged biomedical concerns, including untreated hypertension, dental issues, sleep deprivation, and risk associated with injection drug use. Dimension 3 is elevated due to emotional dysregulation, anxiety, depressive symptoms, and trauma exposure, which increases vulnerability to continued use. Dimension 4 places the client in the contemplation stage as he acknowledges the consequences but remains ambivalent about sustained change. Dimension 5 indicates a high relapse potential, giving ongoing cravings, limited coping strategies and awareness, and a history of continued use despite severe consequences. Dimension 6 reflects an unstable recovery environment due to marital separation, loss of housing stability, unemployment, and limited sober supports. Based on these findings, the ASAM level 3.7 medically monitored residential treatments recommended to address medical risk, stabilize functioning, and create an immediate structured recovery for the client. So Jason's treatment plan is based on his diagnosis. We use the ASSIST scores and using the ASAM recommendation. The three primary goals we identified using the addiction treatment planner were: 1, focus on achieving abstinence from methamphetamine; 2, target goals, relapse prevention and strengthening coping skills; and 3, addressing and improving overall functioning by stabilizing routines and increasing recovery support and daily recovery practice. Each goal includes 2 measurable objectives and evidence-based strategies for abstinence objectives, focusing on identifying triggers, practicing coping skills, and using Best practice CBT interventions. Relapse prevention goals included developing a formal relapse prevention plan written on paper and engaged with the counselor, increasing engagement in structured treatment services as well. The final goal emphasizes improving Jason's daily functioning through routine development, recovery activities, building support, and again, managing a schedule. All objectives that are time aligned and aligned with Jason's readiness to change for this level of care. So CBT was selected as the primary therapeutic modality because of its strong evidence base for treating stimulant use disorders, including meth. CBT helps clients identify the connection between thoughts, emotions, and behaviors, which is particularly important given Jason's impulsivity, decision-making, and his high levels of stress and relapse risk. This approach aligns in the stage of change of contemplation as it supports insight building while encouraging behavioral change. CBT was selected as the primary intervention due to its strong evidence base by treating stimulant use disorders, and then again aligns with this presenting problem. As we can see, we want to make sure CBT is an appropriate fit for his current state of change. It seems that he recognizes the negative consequences of his substance use being in contemplation, but is consistently ambivalent about sustained behavioral change. Using CBT allows for the collaborative goal setting between the client's internal beliefs as well as the recovery environment and therapeutic setting. The skill building without requiring immediate commitment to abstinence makes it well suited for this individual. Its structured skill-based approach supports trigger identification, cognitive restructuring, and behavioral planning to reduce relapse risk over time and continue to support recovery. So here are the discussion questions we have for you guys. The first question invites us to critically evaluate the ASAM and assess the level of care recommendation. We encourage reasoning rather than just simple agreement. The second question focuses on trauma-informed care by examining how adverse childhood experience can contribute to substance use patterns, emotional regulation difficulties, and relapse vulnerability. The third question encourages application of motivation and engagement strategies appropriate for the client in the contemplation stage, emphasizing counselor approach, pacing, and alliance building rather than confrontation. These questions are designed to support thoughtful discussion and application, of course, real world application in clinical decision making. And here are our references. Thank you so much, guys. Again, I'm
Thank you.
Stephen.
I'm Trina.
Alyssa.
Thanks.